Good evening everyone. This is from Everest Surgeon and today we are going to deal about the fluid therapy in surgery and we are taking reference from standard books such as Savistton and Paliello and Schwartz. So coming to introduction, so why this fluid therapy is important as a surgical aspect, because fluid therapy is daily we need for maintenance of the patient, management of the patient during perioperative workup. It includes during preoperative, intraoperative and postoperative adequate resuscitation of the patient so that patient should not get harmed by excessive fluid or under resuscitation of the fluids. So what are the aims of fluid resuscitation? It leads to maintenance of tissue perfusion, preserve intravascular volume and correct the electrolyte imbalances, replaces ongoing losses and prevent the fluid overload and dehydration of the patient. So coming to basic, what is the body fluid compartments? So body fluid compartments in adult male, it is 60% of the body weight it is made up of fluids, and in adult females 50% of the body weight is made up of fluid. So we divide the body compartment into two parts, that is intracellular fluid and extracellular fluid. Intracellular fluid is made up of 2/3 of the total body water, whereas extracellular fluid is made up of 1/3. And extracellular fluid compartment is also divided into interstitial fluid, that is made up of 75% of extracellular fluid compartment and 25% is made up of our plasma volume. So this is the compartmental divide of the body fluid. So coming to the fluid physiology, extracellular fluid is made up of, as I said, 75% interstitial, 25% is plasma. Suppose we are going to infuse any patient with 1 liter of normal saline or any kind of crystalline fluid, only 250 ml of it is retained in the plasma and 750 ml it is distributed to the interstitial or third space, which leads to the tissue edema, which leads to ARDS, bowel edema or any side of edema to the patient, which leads to anastomotic dehiscence and pulmonary edema. So fluid resuscitation is very much important. So basically this is the daily water balance for the normal patient. Will take the daily oral fluids and food, which leads to approximately 2 liter, and metabolic water, that is any kind of oxidation happening in the body, which produces 300 ml approximately. So for the ideal patient, total daily intake of fluid is approximately 2.3 liter per day. And coming to the daily output, that urine for normal patient output is up to 800 to 1.2 liters per day, and stool it is up to 100 to 250 ml per day, and there are insensible losses of fluid, that is approximately 600 ml per day. So this insensible water loss is happening 75% of the skin due to evaporation and due to respiration from the lungs, which increases during fever, burns and tachypnea. So while calculating the fluid requirement of the patient, we have to keep in mind how much is daily input and how much is daily output. So we have to calculate insensible water losses also for daily output, not only just our basic urine output, drain output or Rayleigh tube output. There are insensible water losses, that is approximately 600 ml per day, that we have to add during calculation of our fluid intake and output chart. So this is the daily basic electrolytes requirement, because when calculating the fluid infusion, we should not keep only in the mind fluid infusion, we have to correct the electrolyte imbalances also, because if we infuse the patient with the lesser rate, that leads to under perfusion, and that leads to hypervolemia and hyperconcentration and accumulation of excessive electrolytes. If you perfuse the patient excessively, that leads to dilutional hyponatremia and many electrolyte imbalance. So while calculating the fluid infusion, we have to keep in mind also electrolyte imbalance. So basic sodium requirement is up to 70 to 100 ml millimole per day. Potassium is up to 40 to 80 millimole per day. Chloride is 70 to 100 millimole per day. And basically we have to supplement glucose 50 to 100 gram per day. This is the ideal fluid calculation we have to add along with our fluid, not only just a fluid but also electrolytes, and we have to keep in mind glucose also. So daily salt requirement is approximately 3 to 5 gram of sodium chloride per day, which is equivalent to 50 to 100 millimole of sodium per day. So basically whatever surgical patient we are seeing, the patient will be having GI secretory losses which are slightly hypotonic to isotonic. It means it contains both water and electrolytes. Example, patient is a case of acute obstruction leads to vomiting. We have kept Ryle's tube, so there is a nasogastric aspiration. Patient is having due to enema or any kind of irritable bowel syndrome, patient is having diarrhea or any kinds of intracutaneous fistula, any kind of ileostomy output. So our GI secretions, basically these are the isotonic to slightly hypotonic. So which type of patient we are dealing with, that is also important. So based on that we will be dealing the fluid management. So coming to surgical importance, so whatever the surgery, due to perioperative stress, due to anesthesia stress, due to psychological stress, so patient will be in the lots of stress during the perioperative period. So what happens during the perioperative period, there is a stress response and basically antidiuretic hormone is released. So whenever there is antidiuretic hormone is released, it leads to water retention and leads to the hyponatremia. So suppose patient is having already antidiuretic release and patient is body is trying to compensate more water, preventing more water loss, and we are giving excessive fluid to the patient in which form, either it could be crystalloids, colloids or any kind of blood transfusion. It leads to the patient for overperfusion and fluid overload. So always keep in mind, surgery leads to perioperative stress, releasing of antidiuretic hormone, so which causes water retention, and if you are also giving the fluids, it leads to the excessive water in the patient or circulation in the patient. And also during surgery, it can be due to any kind of fluid loss or it can be due to any kind of blood loss. So there is a third space losses, and also due to surgery or due to any kind of trauma, patient will be having endothelial injury due to excessive kinetics, due to excessive coagulation cascade, endothelial injury. So patient will be having leaky capillaries. So leaky capillaries leads to intravascular depletion of the any kind of fluid. So whatever fluid is going to accumulate in the interstitial edema. So patient is having shock or patient is having any kind of injuries. So patient is having leaky capillaries. You are infusing the patient. Whatever you are going to infuse, till the acute insult is going to relieve, your fluid is going to accumulate in the interstitial compartment. It leads to interstitial edema, and your patient is having leaky capillaries. So basically our ECF extracellular fluid contains predominantly cation as the sodium and also anion as chloride and bicarbonate, and predominant intracellular fluid contains potassium as a cations, and predominant anions are phosphates, sulfates and proteins. So whatever sodium containing fluids we are giving, it is going to expand our extracellular fluid, and only 25% of it will remain in the intravascular fluid. So this you should keep in the mind in cases of patient with a cardiac disease, patient with the cases of renal disease, or patient is a case of any kind of fluid overload status, so that you should avoid maximum sodium containing fluids, because it leads to the excessive accumulation of fluid in the extracellular fluids. It leads to the fluid overload and edema to the patient. So whenever you are going to infuse the fluid, also we have to keep in mind what is the urine output of the patient. Okay? So what is basically urine output, we have to keep normal urine output up to 0.5 ml per kg per hour. This is the normal urine output. So based on urine output status also, we have to reduce or increase the fluid requirement. So basically our fluid therapy, it is consist of resuscitation, maintaining the fluid and maintaining the losses happening in the patient. So daily maintenance fluid our should replaces how much is the urine losses from the patient, how much is the stool losses, how much is the insensible losses. So insensible loss is 600 ml per day, and our basic whatever maintenance, there are n number of fluids available in the market. So whatever fluids we are using, it should contain water, it should contain sodium, it should contain potassium, and it should contain glucose. It should not be only plain water. And basically when we see all this aspect, so there is an ideal fluid which is made up of 5% dextrose in 0.45% normal saline and plus or minus KCl. because when you are going to infuse the patient with this combination, so it will provide the glucose, it will provide the your normal sodium, it will provide also potassium, which manage your electrolyte imbalance also. So basically the ideal composition is 5% dextrose in half normal saline with plus or minus KCl. So how to calculate the fluid requirement to the patient? So you can use the Holiday-Segar formula. This is for normal, this is for any kind of perioperative patient. So this is a simple formula. First 10 kg of the body weight you have to be the 100 ml per kg per day. Next 10 kg body weight you have to be the 50 ml per kg per day. Each kg above the 20 kg you have to be the 20 ml per kg per day. Example, we are taking with the 70 kg adults. So first 10 kg you have it will be 1 liter. Next 10 kg it will be approximately 5 ml. Next remaining 50 kg it will be around 1 liter. So your fluid required total is 2500 ml per day. So this is the normal daily water requirement. So basically you have to see the how much each patient is having drain output. You have to calculate the how much patient is having from whatever the abdomen drains. Patient is having output from the Ryle's tube, nasogastric aspiration, how much output is having patient from any kind of ileostomy output, how much output is patient is having from enterocutaneous fistula, how much patient is having output from urine output, and what are the losses from the stool losses, and also you have to calculate the insensible loss. So you have to calculate the total output, you have to monitor along with that you have to calculate the total intake. So based on total intake and output you have to calculate the fluid requirement in the patient, because not all the patient require same amount of the fluid, and you should not be going to resuscitate the same patient with the same formula. So you have to calculate the how much is loss is happening to the patient and correct with the same amount of loss with plus or minus. So depends on the other condition to the patient also. So disturbances in the fluid balance. So suppose if there is any extracellular fluid depletion, if it is acute depletion, such as in case of blood loss, vomiting, diarrhea, burns, though there is a third space losses. So patient will be having reduced circulating blood volume, and it leads to the cardiovascular instability and decreased tissue perfusion. So there is another patient is having chronic small bowel obstruction. Patient is having small irritable bowel syndrome. Patient is having any kind of malabsorption syndrome. So that leads to chronic extracellular fluid depletion. So in that aspect, patient will be having weight loss, reduced skin turgor, and chronic signs of dehydration. This is how you differentiate between acute extracellular fluid depletion and chronic extracellular fluid depletion. So this we have discussed. So basically our ideal fluid is 5% dextrose in 0.45% normal saline. Okay, so we have to start in any kind of patient. If you are not basically you are not known the output and all, so you can start with 100 ml per hour. So once the patient is having adequate urine output, you have to give the, and also normal renal function, add 20 milliequivalent of KCl per liter of whatever fluid mentioned. See, basically till the normal renal function, till the normal urine output, you should not infuse patient with the potassium containing electrolytes, because it leads to patient is having also acute kidney injury or kind of chronic kidney injury, it leads to hyperkalemia. So whatever replaces daily water requirement, provide the glucose, because maintaining glucose level is also important. Maintain intravascular volume, and also see whatever the potassium is level to the patient. Important rule: never add potassium until urine output is established adequately. So what are the types of fluids we are dealing with? So there are the crystalloids. So crystalloids, first crystalloid we are doing the normal saline, that is 0.9% of normal saline weight by volume of sodium chloride. So it is not a normal, it is a misnomer, because it is having osmolarity more than plasma. So it is a simple sodium chloride salt with dissolved in 1 liter of water. So basically it contains both sodium 154 milliequivalents per liter and chloride 154 milliequivalents per liter. So basically this is the universal fluid available everywhere. This is the cheapest fluid. This is the easily accessible fluid. So this is this fluid we are going to see in the all the daily usage in the hospital. So basically we can use in the hypovolemia, you can use the GI losses, you can use in the any kind of shock, and you can use in the hyponatremia patient. So remember, whenever a patient is having contraction alkalosis is because of excessive vomiting leads to ECF depletion, extracellular fluid depletion. In that aspect, you need fluid replacement. So in that aspect, contraction alkalosis, there is a loss of chloride also leads to loss of chloride and loss of sodium also from the body. So body will tends to retain the sodium and chloride by excreting our potassium and hydrogen ions. So in that leads to state of metabolic alkalosis. So that is a term called as contraction alkalosis. So in contraction alkalosis, fluid of choice is our normal saline. So basically, whenever there is a excessive usage of normal saline due to excessive chloride, it leads to formation of hyperchloremic metabolic acidosis, because whatever you are going to infuse the larger volume of normal saline, it produces acidosis by dilution of our serum bicarbonate level. So it leads to formation of hyperchloremic metabolic acidosis. This is one of the disadvantage of our normal saline. So to overcome these excessive chloride levels, we are converting our fluid with anions. We are using the lactate. So basically this is the ringer lactate. It contains lesser quantity of sodium and also potassium, and it also contains calcium, and there is a lactate. So basically ringer lactate, it reduces our chloride level. So it also advantage, it contains calcium and also lactate. So basically we can use in the any kind of trauma patient, burns, or any kind of peritonitis, and also surgical resuscitation. So advantage of ringer lactate, it is the balanced crystalloid. So whatever there is the ringer lactate is there, it is going to convert it to bicarbonate in the liver. So we can use in the any kind of acidotic state. So fluid of choice in the acidotic state, or any kind of peritonitis, or any kind of GI loss, or any kind of, if you need balanced crystalloid, so we are having the ringer lactate. So in this ringer lactate, there is a D lactate and L lactate, but our D lactate is, according to theoretical aspect, it is the dangerous component. So coming to next, so this is the table taken from our book, Sapiston book. So basically normal saline contains sodium 154 and chloride 154, and it is having osmolarity of 308, but compared to plasma it is having osmolarity of up to 280 to 295. Our ringer lactate is having osmolarity of 273, and coming to next fluid, that is the plasmalite, it is having almost osmolarity similar to plasma, that is 294. So hence name it is as given as a plasmalite. So along with sodium, potassium, our plasmalite is also containing magnesium. So we can use in the magnesium deficiency state. So fluid of choice in the magnesium deficiency state is the plasmalite. But remember, whenever the patient is having any kind of acute kidney injury or chronic kidney injury, magnesium infusion should be in the check. So our plasmalite is also having other components such as gluconate, which other fluid is not having. So plasmalite is the ideal fluid which is having osmolarity similar to plasma and also having pH similar to plasma, that is 7.4. So coming to fluid of choice in surgical patients, suppose clinical situation, if you are having any kind of trauma patient with shock, we are going to infuse the patient with ringer lactate, plasmalite, and patient with burns, fluid of choice is ringer lactate. Patient with septic shock, we have to infuse the patient with our balanced crystalloids, because patient will be having leaky capillaries. And patient with cases of any kind of GI gastrointestinal losses, so we have to infuse the patient with half normal saline with the dextrose composition, and whenever the patient is having adequate urine output, we have to infuse the patient with 20 milligrams per kcl. So that is the fluid of choice for the GI losses. And suppose if any patient is having symptomatic hyponatremia, we can use the hypertonic saline such as 3% saline. And if patient is any kind of patient, if we are dealing with hypernatremia, instead of using the hypertonic saline, use the half normal saline or D50% of weight dextrose fluid we can use. First 24 hour post-operative any kind of period, first 24 hours of period, always use the isotonic crystalloids. Avoid normal saline, avoid crystalloids during the initial 24 hours period of post-operative, because patient will be having surgical stress, leaky capillaries, so it leads to accumulation of third space losses. So once your 24-hour post-operative period is over, maintenance fluid should be replaced with D5 with half Na solution. So this is the ideal way to manage the patient with ideal fluids. So post-operative, any kind of post-operative fluids, you can use the ringer lactate, you can use the plasmalide. Normal saline in selected patient. Never use the normal saline in all the patient, because surgical causes releases antidiuretic hormone release, as I told in the beginning, which leads to accumulation of sodium, and accumulation of fluid leads to formation of hypernatremia, and also patient will having increased risk of post-operative hypernatremia due to ADS release. After 24 hours you can use the D5 with 0.5% of normal saline. So how to monitor the fluid balance? So earliest sign of fluid excess is the weight gain. You have to keep in the mind the patient is having any signs of peripheral pedal edema, patient is having increased JVP or increased central venous pressure, patient is having bilateral crepes, patient will be having facial puffiness. So these are the signs of fluid excess. Along with that, you have to monitor the weight of the patient every day, so that you have to see the weight gain. So average physiological, whatever the surgery you are doing, average physiological post-operative weight loss is up to 0.25 kg per day. Okay, so you have to keep in mind there is an average weight loss of 0.25 per kg per day. If your patient is having excessive weight gain, you should consider you are infusing more fluid to the patient. So you have to monitor daily body weight, intake output chart, urine output. You have to monitor the serum electrolytes and also renal function test. So if you infuse the patient with excessive fluid, patient will be having weight gain, peripheral edema, rise in central venous pressure, pulmonary edema, patient will be having tachypnea, and also important our surgical complex, patient will be having, due to excessive fluid, patient will be having delayed wound healing, patient will be having chances of anastomotic leakage, patient will be having tissue edema or bowel edema, and most important deadliest complication is patient will be having abdominal compartment syndrome, which manifests multiple way, leads to respiratory failure. Patient will be having, due to abdominal compartment syndrome, patient will be having acute kidney injury and all. So remember one thing, most abundant extracellular cation is the sodium, most abundant intracellular cation is the potassium, major source of insensible loss is the skin, percentage of crystalloid remaining in the intravascular fluid after resuscitation is only 25%. So minimum acceptable adult urine output is 0.5 ml per kg per hour. So these are the some of the important MCQ points also. So fluid of choice in surgery, we are coming to summarize this. So when you are going to resuscitate any kind of patient in trauma, septic shock, or any kind of peritonitis or any kind of burns, so basically go with the balanced crystalloids with ringer lactate or plasmalide. If you are having predominant GI losses, then replace with normal saline with plus or minus or potassium with dextrose supplementation. Suppose if you are having hypernatremia, you can use the half normal saline or D5% of dextrose. So if patient is having symptomatic hyponatremia, then use the 3% hypertonic saline as required after calculation of the required sodium. And basically after 24 hours post-operative period is over, you have to switch off fluid to the balanced crystalloid with appropriate electrolyte supplementation. Thank you.